Meningitis occurs when an infection, usually viral or bacterial, invades the meninges, which are the protective layers covering the brain and spinal cord. This invasion triggers inflammation, and that inflammation is what leads to the majority of symptoms the patient experiences. In bacterial meningitis, the body produces a purulent exudate, which is a thick pus-like fluid made of white blood cells, bacteria, and cellular debris. This exudate can accumulate in the subarachnoid space and around the brain, making the tissues swollen and irritated. As inflammation increases, so does intracranial pressure. We call this increased ICP, and it happens because swelling, exudate buildup, and decreased cerebrospinal fluid flow all create pressure inside the skull. Remember that the skull is a closed space. There is no flexibility, so any swelling can quickly impair blood flow and reduce oxygen to brain tissue. This is why early recognition and treatment are critical. Inflammation can also spread to or compress nearby cranial nerves. This may cause complications such as hearing loss, vision changes, facial weakness, or difficulty swallowing. Cranial nerve 8, the vestibulocochlear nerve, is especially vulnerable in bacterial meningitis, and damage can lead to hearing loss, sometimes permanently. As nurses, recognizing changes in cranial nerve function is important because these deficits can be early signs that the infection is progressing. Overall, the pathophysiology of meningitis is a combination of infection, inflammation, rising pressure, and potential nerve involvement, all of which can rapidly threaten neurological function if not managed promptly. One of the hallmark symptoms of meningitis is a severe headache. This headache is often described as the worst of my life because the meninges are inflamed and extremely sensitive to pressure or movement. Many patients also lose their appetite or thirst. This happens because the body is mounting a strong inflammatory response, and the brain may be affected enough that normal hunger and thirst signals are suppressed. Fever is almost always present, especially in bacterial meningitis, because the immune system is fighting an active infection. Along with fever, we see photophobia, which means that light becomes painful. This occurs because the inflamed meninges make the brain more sensitive to sensory input. In certain types of bacterial meningitis, especially meningococcal infections, patients may develop a petechial rash. These are tiny red or purple pinpoint spots that do not blanch when pressed. They occur because the bacteria damage the blood vessels, causing bleeding under the skin, and this can signal a life-threatening infection. Another key assessment finding is nuchal rigidity, meaning the neck is stiff and difficult to move. This is a classic sign of meningeal irritation. We also check for Kernig and Brudzinski signs. A positive Kernig sign appears when the patient experiences pain and resistance, when the hip is flexed and the knee is extended. Brudzinski's sign is positive when lifting the patient's head causes their hips and knees to involuntarily flex. Both signs show irritation of the spinal meninges. Nausea and vomiting occur because increased intracranial pressure affects the vomiting center in the brain. Finally, some patients develop encephalopathy, which means the infection is affecting brain function itself. You may see confusion, irritability, decreased responsiveness, or even seizures. Any change in mental status in a patient with suspected meningitis must be treated as an emergency because it indicates that intracranial pressure may be rising or that infection is spreading into brain tissue. Together, these symptoms help us identify meningitis quickly and get treatment started before permanent neurological damage occurs. Kernig and Brudzinski signs are classic assessment findings used to help identify meningeal irritation, such as in meningitis. These signs are not diagnostic by themselves, but when present, especially along with fever, headache, and nuchal rigidity, they strongly support the suspicion of meningitis and help guide the need for immediate medical evaluation. Let's start with Kernig's sign. To assess for Kernig's sign, the patient lies flat on their back. You flex the hip and knee to form a 90-degree angle. When you attempt to extend the knee while the hip remains flexed, a positive Kernig's sign occurs if the patient experiences pain, resistance, or muscle spasms in the hamstring area. This happens because stretching the inflamed meninges irritates the spinal nerves. The learning tip on the slide is a great way to remember it. Kernig starts with a K, and you are checking the knee. Brudzinski's sign is assessed differently. The patient again lies flat, and you gently lift the back of their head to flex the neck. A positive Brudzinski sign occurs when the patient's hips and knees automatically flex in response to the neck movement. This is the body trying to reduce the stretch and pain caused by inflamed meninges. The memory cue is helpful here as well. Brudzinski starts with B, and you lift the back of the head to check for it. These two signs indicate meningeal irritation and can be early warning clues that the central nervous system is inflamed. As LPNs, you may not be the one performing the full neurological exam, but you are responsible for recognizing these indicators, reporting them immediately, and understanding their significance in a potentially life-threatening condition like meningitis. Diagnosis of meningitis. The most important and definitive test is the lumbar puncture, also known as a spinal tap. During this procedure, cerebrospinal fluid, CSF, is collected from the lower back. The CSF is then analyzed for color, glucose levels, protein, white blood cells, and the presence of bacteria or viruses. In bacterial meningitis, the CSF typically shows cloudy fluid, very high white blood cell counts, elevated protein, and low glucose levels because bacteria consume glucose. A lumbar puncture must be performed as soon as it is safe to do so because the results guide immediate treatment. After CSF is collected, the lab performs a culture and sensitivity, or CNS. This identifies the exact organism causing the infection and determines which antibiotics will be effective against it. While culture results take time to finalize, they are essential in ensuring the patient receives the correct targeted therapy, especially with resistant organisms becoming more common. Before performing a lumbar puncture, many patients undergo imaging such as a CT scan or MRI. These scans are done first if there is any concern for increased intracranial pressure, brain swelling, a mass, or neurological symptoms like decreased consciousness. CT and MRI help the healthcare team ensure that it is safe to remove spinal fluid because performing a lumbar puncture in a patient with dangerously high intracranial pressure could lead to brain herniation, which is life-threatening. Imaging also helps identify complications such as abscesses, inflammation, or bleeding. Ultimately, the combination of CSF analysis, culture, and imaging gives a full picture of what is happening inside the central nervous system and helps guide urgent treatment. Treatment for meningitis begins immediately, especially in suspected bacterial meningitis, because rapid progression can lead to brain damage, sepsis, or death. The first priority is early administration of antibiotics. These are given intravenously and are started even before culture results come back. Once culture and sensitivity findings return, antibiotic therapy is adjusted to a more targeted drug. Viral meningitis, on the other hand, does not respond to antibiotics, so treatment is mainly supportive unless the virus requires antiviral therapy, such as acyclovir for herpes-related infections. Antipyretics such as acetaminophen are used to manage fever and help reduce metabolic demand on the brain. A cooling blanket may also be used if the patient has high, persistent fevers. Care must be taken to avoid causing shivering, because shivering increases metabolic activity and can worsen intracranial pressure. It is also very important to maintain a dark, quiet environment for these patients. Because meningitis increases sensitivity to light and noise, minimizing stimulation helps reduce discomfort and prevents spikes in intracranial pressure brought on by agitation. Pain control is essential, and analgesics are used to help relieve the severe headache associated with meningitis. Codeine-containing medications may be used because they help manage pain without significantly increasing sedation, which allows staff to monitor neurological status more accurately. However, nurses must monitor for respiratory depression and constipation, effects that opioids can cause. Corticosteroids may be ordered, especially in bacterial meningitis, to reduce inflammation around the meninges and to help prevent long-term complications such as hearing loss. These are often given before or with the first dose of antibiotics. Antiemetics help control nausea and vomiting caused by increased intracranial pressure and can prevent aspiration. Finally, if the meningitis is bacterial or suspected to be bacterial, the patient is placed on droplet isolation to prevent the spread of infection. This involves wearing a surgical mask within 3 feet of the patient and keeping the patient in a private room. Droplet precautions stay in place for at least 24 hours after starting effective antibiotics. Rapid isolation protects staff, visitors, and other patients from pathogens like meningococcal bacteria, which can spread easily through respiratory droplets. Encephalitis is different from meningitis because instead of affecting the protective layers around the brain, encephalitis involves direct inflammation of the brain tissue itself. This inflammation is most often caused by viral infections such as herpes simplex virus, West Nile virus, or other mosquito or tick-borne viruses. Because the brain tissue is directly affected, encephalitis tends to cause more profound neurological changes than meningitis. Patients may develop altered cognition, seizures, personality changes, or even coma. As the virus or infectious agent invades brain cells, it triggers an immune response that leads to nerve damage, swelling, edema, and even necrosis, which is the death of brain cells. This tissue injury interrupts normal electrical activity in the brain and can cause long-term neurological deficits depending on the area affected. For example, inflammation in the temporal lobes, common with herpes simplex encephalitis, can result in memory loss or behavioral changes. All of this damage and swelling contributes to increased intracranial pressure, or ICP. As the brain swells inside the fixed space of the skull, pressure rises and can reduce blood flow to the brain. Without adequate oxygen and perfusion, additional brain injury can occur. Increased ICP is one of the major reasons encephalitis is considered a medical emergency. As LPN students, it is important to recognize that encephalitis affects brain tissue directly, leading to more severe neurological manifestations and requiring urgent treatment to prevent permanent deficits. Signs and symptoms of encephalitis. Because encephalitis involves inflammation of the brain tissue itself, many of the symptoms overlap with meningitis, but encephalitis typically causes more profound neurological changes. Patients often begin with a headache, fever, and nausea or vomiting, which are common early signs of infection and inflammatory response. Some patients also develop nuchal rigidity, although this is more strongly associated with meningitis. As encephalitis progresses, the patient may show confusion or behavioral changes, which reflect irritation and swelling of the brain. A decreased level of consciousness ranging from lethargy to unresponsiveness is an early warning sign that intracranial pressure is rising or that brain tissue is being damaged. These changes require urgent evaluation. More severe neurological symptoms such as seizures, ataxia, hemiparesis, and tremors occur when inflammation affects areas of the brain responsible for coordination, movement, or electrical activity. Ataxia indicates cerebellar involvement, while hemiparesis suggests injury to motor pathways on one side of the brain. Seizures may occur because damaged or irritated brain tissue begins firing abnormally. Photophobia is also common as the brain becomes more sensitive to stimulation. In the most serious cases, encephalitis can progress to coma and can even be fatal. The severity of symptoms depends on the cause of the encephalitis, how quickly treatment begins, and which areas of the brain are affected. Viral encephalitis, especially herpes simplex encephalitis, can cause rapid and severe deterioration if not treated promptly with antiviral therapy. As future LPNs, it's important to recognize that any sudden neurological changes, especially in a febrile patient, should raise suspicion for encephalitis and require immediate reporting and intervention. Diagnostic tests commonly used to confirm encephalitis. Because encephalitis affects the brain tissue itself, accurate diagnosis requires a combination of imaging, neurological testing, and laboratory analysis. The first diagnostic tools are imaging studies, CT scans and MRIs. A CT scan is often done first because it is fast and widely available. It helps identify bleeding, swelling, or masses that could explain the patient's symptoms or indicate whether it is safe to perform a lumbar puncture. An MRI provides a more detailed picture of the brain and is more sensitive in detecting inflammation, edema, or specific patterns seen in viral encephalitis, such as temporal lobe involvement in herpes simplex encephalitis. MRI findings often guide both diagnosis and treatment decisions. An electroencephalogram, or EEG, is another important tool. Because seizures are common with encephalitis, the EEG helps detect abnormal electrical activity in the brain. It may show slowing, sharp waves, or seizure patterns. These findings support the diagnosis and help guide anticonvulsant therapy. EEGs can also help distinguish encephalitis from other causes of altered mental status, such as metabolic encephalopathy. Finally, a lumbar puncture with CSF analysis is usually essential. CSF in viral encephalitis often shows elevated white blood cells, slightly elevated protein, and normal glucose levels. Specific viral PCR testing can identify the exact virus, such as herpes simplex virus, which is critical because antiviral treatment must begin quickly to prevent severe brain injury. As LPNs, it is important to understand how these tests work together. Imaging ensures safety, EEG evaluates brain activity, and CSF analysis pinpoints the infectious cause. Early diagnosis is the key to preventing long-term neurological damage or death. Therapeutic interventions for encephalitis. Because encephalitis involves inflammation and damage to actual brain tissue, treatment must begin promptly and often requires supportive care in addition to targeted medications. The goals of therapy are to manage symptoms, prevent complications such as seizures or increased intracranial pressure, and treat the underlying cause if one is identified. The first category is analgesics, which are used to relieve the severe headache and general discomfort caused by brain inflammation. Pain control is important, but we also need to avoid oversedation because frequent neurological assessments are necessary. Next are anticonvulsants. Seizures are common in encephalitis due to irritation of the cerebral cortex. Medications such as phenytoin, levetiracetam, or benzodiazepines may be used to prevent or treat seizure activity. Rapid recognition and treatment of seizures is essential because prolonged seizures can worsen brain injury. Antipyretics are given to control fever, which helps reduce metabolic demand on an already stressed brain. Fever increases the body's oxygen needs, so keeping temperature controlled is a critical part of supportive care. Corticosteroids may be used to reduce inflammation and swelling in certain types of encephalitis, although their use depends on the cause. They can help decrease cerebral edema and stabilize neurological function. Because many cases of encephalitis are viral in origin, antiviral medications may be prescribed. Acyclovir is the drug of choice for herpes simplex encephalitis, which is one of the most severe but treatable forms. Early initiation of antivirals dramatically improves outcomes and reduces the risk of permanent brain damage. Sedatives may be required if the patient is extremely agitated, restless, or experiencing seizures. However, they must be used cautiously because sedation can mask mental status changes, the very changes we need to monitor closely. Frequent neurological assessments are essential. Nurses monitor level of consciousness, pupil response, motor function, and signs of increased intracranial pressure. These assessments help determine whether the patient is improving or deteriorating. Finally, symptomatic care includes managing nausea, ensuring adequate hydration, preventing pressure injuries, maintaining a quiet and low stimulation environment, and supporting respiratory function if level of consciousness declines. Encephalitis patients often require multidisciplinary care to prevent complications and protect brain function as healing occurs. To understand intracranial pressure, it's important to remember the Monroe-Kelly doctrine. This principle states that the skull is a closed, rigid compartment containing three main components: brain tissue, blood, and cerebrospinal fluid, or CSF. Because the skull cannot expand, if one of these components increases in volume, one or both of the others must decrease to maintain normal pressure. If compensation can't occur, intracranial pressure begins to rise. The first component is brain tissue. This can increase from swelling, inflammation, tumors, or bleeding into the brain. Conditions like meningitis, encephalitis, stroke, and traumatic brain injury often cause brain edema, which raises pressure inside the skull and limits blood flow. The second component is blood. Intracranial pressure increases when cerebral blood volume rises. This can occur with hypercapnia, elevated carbon dioxide levels, because carbon dioxide causes blood vessels in the brain to dilate. It can also occur with bleeding, such as intracerebral hemorrhage or subdural hematoma. When vessels dilate or blood accumulates, the fixed space in the skull becomes crowded, and pressure rises. The third component is cerebrospinal fluid. Cerebrospinal fluid volume can increase if there is obstruction of cerebrospinal fluid flow, impaired reabsorption, or overproduction, as seen in hydrocephalus. Cerebrospinal fluid buildup increases pressure and can compress brain tissue. As any of these components increase, intracranial pressure rises and can reduce cerebral perfusion, the blood flow that delivers oxygen to the brain. When intracranial pressure becomes dangerously high, it can cause brain herniation, which is a life-threatening emergency. As nurses, especially at the LPN level, it is essential to recognize early signs of increased intracranial pressure and understand what factors contribute to changes in intracranial dynamics. The major signs and symptoms of increased intracranial pressure occur because pressure inside the skull is rising and the brain is being compressed. One of the very first signs we look for is restlessness. Patients may appear unable to get comfortable or may constantly shift or move. This occurs because the brain is becoming irritated as pressure increases. Another early indicator is irritability. Even small stimuli like noise, touch, or bright light can cause agitation. These behavioral changes often appear before major neurological deficits, which is why they are so important for nurses to recognize. Early findings such as restlessness and irritability are the body's warning signs that the brain is under stress. A decrease in level of consciousness, or LOC, is one of the most reliable indicators of increasing ICP. Patients may progress from being alert to lethargic to difficult to arouse. This happens when pressure interferes with the brain's reticular activating system, the center responsible for maintaining wakefulness. Any drop in LOC should be treated as an urgent finding. Hyperventilation can also occur. This is the body's attempt to lower carbon dioxide levels. Because CO2 causes blood vessels in the brain to dilate, blowing off CO2 helps constrict vessels and temporarily reduce blood volume in the skull. Hyperventilation is therefore a compensatory response, but once it appears, ICP is often significantly elevated. Next are pupil changes. As pressure increases, it may compress cranial nerve 3, the oculomotor nerve, leading to dilation of one pupil, sluggish reaction to light, or unequal pupils. Pupil changes are signs of worsening compression and must be reported immediately because they often precede brain herniation. Finally, we see Cushing's triad, which is a late and ominous sign of dangerously high ICP. Cushing's triad includes 3 findings: elevated systolic blood pressure with a widening pulse pressure, bradycardia, and irregular respirations. This pattern occurs when the brainstem is under severe pressure, and it indicates impending herniation. Once Cushing's triad appears, the patient requires emergency intervention to prevent death. Early recognition of these signs is one of the most important nursing responsibilities when caring for patients at risk for increased ICP. This images on this slide show 2 common methods used to monitor and manage increased intracranial pressure. These techniques are used in critical situations where the healthcare team needs continuous information about pressure inside the skull, or when cerebrospinal fluid drainage is required to reduce pressure and prevent further brain injury. While LPNs do not insert or adjust these devices, you will care for patients who have them and must understand their purpose, how they work, and early signs that something may be wrong. The image on the left shows a ventriculostomy, also called an intraventricular catheter. This is the most accurate method for measuring intracranial pressure and the only device that allows both monitoring and direct drainage of cerebrospinal fluid. The catheter is surgically inserted into one of the lateral ventricles of the brain. It connects to a pressure transducer and a cerebrospinal fluid drainage system. By draining small amounts of cerebrospinal fluid, the healthcare team can quickly lower intracranial pressure. As nurses, we monitor the drainage amount, maintain sterile technique at all times, and ensure the system is leveled correctly at the patient's tragus, the anatomic reference point for accurate intracranial pressure readings. The image on the right shows a subarachnoid bolt or screw. This device is inserted through the skull and sits in the subarachnoid space. A pressure transducer measures ICP, but unlike a ventriculostomy, this device does not allow cerebrospinal fluid drainage. It is less invasive and easier to insert, but does not provide the same level of precision. Because the bolt accesses the subarachnoid space, strict infection control is essential. Nurses monitor the site for drainage, redness, or signs of meningitis. Both systems require careful handling. The head of the bed is usually kept elevated 30 degrees to promote venous drainage and reduce intracranial pressure. The patient must avoid neck flexion and extreme hip flexion. It is also crucial to minimize stimulation, maintain pain control, and ensure proper alignment. Any sudden change in intracranial pressure readings, such as a rapid increase, must be reported immediately, as it may signal worsening swelling, obstruction of cerebrospinal fluid flow, or impending herniation. Understanding these devices helps LPNs play a key role in monitoring, preventing complications, and ensuring patient safety. There are two major categories of headaches: primary headaches and secondary headaches. As LPN students, it's important to understand that primary headaches are disorders in which the headache itself is the main medical problem. There is no underlying disease causing them. These headaches tend to be recurrent and chronic, and they are usually diagnosed based on symptom patterns rather than imaging or lab tests. The first primary headache type is a migraine. Migraines are often described as throbbing or pulsating, typically on one side of the head, and can last for hours to days. They are frequently accompanied by nausea, vomiting, and sensitivity to light or sound. Some people experience auras, which are warning sensations such as visual changes or numbness. Migraines are linked to changes in brain chemicals, blood vessel dilation, and genetics. The second type of primary headache is a tension headache. This is the most common type and is often described as a tight band around the forehead or pressure at the temples or back of the head. Tension headaches are usually caused by stress, muscle tightness, or poor posture. They are typically mild to moderate and do not include neurological symptoms such as aura or severe nausea. The next type of primary headache is the cluster headaches, which are extremely painful and occur in patterns or clusters. They typically present as sudden, sharp, burning pain around one eye, often with tearing nasal congestion or drooping eyelid on that side. They occur in cycles, often the same time each day, and are more common in men. Cluster headaches have a strong neurological component involving the hypothalamus. The final category listed is other primary headaches, which can include chronic daily headaches, exertional headaches, or headaches triggered by coughing or sexual activity. These are less common, but still not caused by an underlying medical condition. In contrast, secondary headaches occur because something else is wrong in the body. In these cases, the headache is a symptom, not the disease. Causes include head or neck trauma, such as concussion or whiplash, which lead to inflammation or structural injury. They may also occur from infection, such as sinusitis, meningitis, or encephalitis. These are especially important to identify because the underlying condition may be serious or life-threatening. The slide also includes other causes, which can include brain tumors, medication overuse, high blood pressure, or problems with cerebrospinal fluid flow. Secondary headaches require further investigation to identify and treat the underlying cause. In nursing practice, recognizing warning signs, such as sudden severe headache, neurological changes, or fever, helps guide urgent intervention and safe patient care. A structured approach helps ensure the nurse gathers all the relevant information needed to identify the type of headache, determine severity, and recognize red flags that may indicate something more serious. The mnemonic "What's up" is a simple and effective way to guide the assessment. The first question is, where is the pain? Understanding the location, whether it is unilateral, bilateral, frontal, temporal, or behind the eye, helps differentiate between types of headaches. For example, cluster headaches often occur around one eye, while tension headaches tend to involve both sides of the head like a tight band. Next, we ask, how does the headache feel? This is where the patient describes the quality of the pain: throbbing, sharp, dull, pressure-like, burning, or stabbing. The quality often gives important clues. Migraines, for example, are commonly described as pulsing or throbbing, while tension headaches feel more like pressure or tightness. The A stands for aggravating or alleviating factors. We ask what makes the headache worse: light, noise, stress, certain foods, physical activity, and what helps relieve it, such as rest, quiet, dark rooms, or medications. Identifying triggers is essential for patient teaching and prevention. Timing is the next component. When does the headache typically occur, and how long does it last? Some headaches have distinct patterns. Migraines may last hours to days, while cluster headaches occur in short, explosive episodes. Timing also helps determine whether the headache is new or chronic and whether it follows a cyclical pattern. Severity is another important detail. We ask the patient to rate the pain, usually using the 0-10 scale. Severity helps determine the urgency of interventions and can provide a baseline for evaluating response to treatment. A sudden, severe headache described as the worst headache of my life may indicate a medical emergency, such as subarachnoid hemorrhage. We also ask about other useful data. This can include nausea, vomiting, vision changes, sensitivity to light or sound, recent illnesses, medications, sleep patterns, hydration, and menstrual cycles. These details help differentiate among headache types and identify possible underlying causes. Finally, we explore the patient's perception of the headache. How does it affect their daily functioning? Do they feel anxious or fearful about it? Understanding the patient's concerns helps guide teaching, reassurance, and individualized intervention. Collecting thorough data is the first step in safe and effective nursing care for patients with headaches. A seizure occurs when there are sudden abnormal bursts of electrical activity in the brain. Normally, brain cells, called neurons, communicate in an organized, controlled pattern. But during a seizure, this electrical activity becomes chaotic and excessive. The slide mentions instability of neuronal cell membranes, which is accurate. When these membranes become overly excitable or disrupted, neurons fire uncontrollably. This can result from many causes such as electrolyte imbalances, high fevers, infections, head injuries, or chronic disorders like epilepsy. Seizures are classified into two main categories, partial and generalized. Partial seizures, also called focal seizures, begin on one side of the cerebral cortex. Because they originate in a specific area of the brain, the symptoms depend on which part is affected. For example, a focal seizure in the motor cortex may cause jerking movements of one limb, while one in the temporal lobe may cause unusual sensations, emotions, or repetitive behaviors. Some partial seizures impair awareness while others do not. These seizures can also spread and become generalized. Generalized seizures, on the other hand, involve both hemispheres of the brain from the outset. Because the entire brain is affected, generalized seizures often result in loss of consciousness. These include several types such as tonic-clonic seizures, absent seizures, myoclonic seizures, and atonic seizures. Tonic-clonic seizures are the most well-known, involving stiffening, rhythmic jerking, and a period of postictal confusion afterward. Absent seizures are brief staring spells and are more common in children. Understanding how seizures are classified helps nurses recognize what type of seizure they are observing and guides appropriate interventions. Identifying whether a seizure is focal or generalized also helps providers determine the underlying cause and select the most effective treatment. As LPNs, your role includes observing and documenting seizure activity thoroughly, monitoring for safety, and understanding what actions to take during and after a seizure episode. Let's discuss the signs and symptoms associated with seizures, focusing specifically on auras and partial seizures. Some patients experience an aura, which is an early warning sign that a seizure is about to occur. An aura is actually a simple focal seizure that affects only a small region of the brain, but serves as a signal that a larger seizure may follow. Auras can appear as visual distortions, such as flashing lights, zigzag lines, or blind spots. They may also include unusual odors, often described as burning, metallic, or chemical smells. Some patients report sudden changes in sound perception, such as buzzing, ringing, or muffled hearing. Auras are important because they give patients time to move to safety or alert others before losing awareness. Then there are symptoms associated with partial seizures, also known as focal seizures. One hallmark symptom is automatisms. These are repetitive, involuntary movements such as lip smacking, chewing, swallowing, picking at clothing, or rubbing fingers together. Patients are often unaware they are doing these actions. Another key feature is that many focal seizures maintain consciousness, especially focal aware seizures. The patient may appear awake but unable to respond normally, or they may experience sensations or movements without losing awareness. These seizures are typically brief, usually lasting less than 1 minute, which helps differentiate them from generalized seizures. Paresthesias are abnormal sensations such as tingling, numbness, or pins and needles. These occur when a focal seizure affects the sensory cortex. Additionally, visual disturbances may occur if the seizure originates in the occipital lobe. These can include flashing lights, blurred vision, or temporary loss of part of the visual field. Recognizing these specific signs helps nurses correctly identify seizure activity, document accurately, and provide appropriate care. It also assists the healthcare team in identifying the type of seizure and the part of the brain involved, which guides further diagnostic testing and treatment planning. Further signs and symptoms are associated with complex partial seizures and generalized seizures. Complex partial seizures, also called focal impaired awareness seizures, originate in one specific part of the brain but affect areas responsible for consciousness. Because of this, patients typically lose consciousness, or more accurately, lose awareness of their surroundings. They may appear awake but are not able to respond appropriately. These seizures usually last 2 to 15 minutes, which is longer than simple partial seizures. During this time, patients may demonstrate automatisms such as lip smacking, wandering, or picking at clothing. Afterward, they are often confused or fatigued as they recover. Next, we look at generalized seizures, which affect both hemispheres of the brain from the start. One type is the absence seizure, also known as petit mal. These occur most commonly in children and are characterized by a brief period of staring. The patient may appear to zone out, stop speaking mid-sentence, or blink repeatedly. These episodes last only a few seconds, and the patient is often unaware anything happened. They do not typically involve loss of muscle tone or major body movements. The more dramatic form of generalized seizure is the tonic-clonic seizure. These seizures may begin with an aura, which acts as a warning sign for some individuals. During the tonic phase, the patient becomes rigid as muscles suddenly contract. This may cause them to fall if standing. This is followed by the clonic phase, which involves rhythmic jerking of the arms, legs, or whole body. During tonic-clonic seizures, patients usually lose consciousness. Because of the full body involvement, incontinence, either urinary or bowel, may occur. After the seizure ends, the patient enters the postictal period. This recovery phase can last minutes to hours. During this time, patients are often confused, drowsy, disoriented, or may sleep deeply. Headache, muscle soreness, and fatigue are also common. Understanding these phases helps nurses respond appropriately, provide reassurance, and monitor patients for safety and complications. Documenting what you observe, including duration, movements, awareness, and recovery, is essential for accurate diagnosis and treatment planning. Status epilepticus is a life-threatening neurological emergency. Status epilepticus occurs when a patient experiences 30 minutes or more of continuous seizure activity, or when repeated seizures occur without the patient regaining consciousness between them. Although the slide states the traditional definition of 30 minutes, it's important to note that clinically, treatment should begin much earlier, usually after 5 minutes of continuous seizure activity. Because the longer a seizure lasts, the higher the risk of permanent brain damage, respiratory arrest, and death. The first therapeutic priority in status epilepticus is to ensure airway and oxygenation. During prolonged seizures, the patient may not be able to maintain an open airway, may stop breathing effectively, or may aspirate saliva or vomit. Oxygen saturation can drop quickly due to increased metabolic demand and impaired ventilation. Nurses must protect the airway, position the patient on their side if possible, provide supplemental oxygen, and be prepared for suctioning. In severe cases, endotracheal intubation may be required to maintain adequate oxygenation. The next intervention is the rapid administration of benzodiazepines, which are the first-line medications for stopping seizure activity. The slide lists diazepam, Valium, and lorazepam Ativan, both of which are correct. Lorazepam is often preferred in hospital settings because it has a longer duration of action in the brain. These medications act quickly to calm neuronal activity and interrupt the seizure. They can be given intravenously, intramuscularly, or even rectally in emergency situations, when IV access is not yet available. After benzodiazepines are given, additional anti-seizure medications, such as fosphenytoin, levetiracetam, or phenobarbital, are typically administered to prevent recurrence. Supportive care includes continuous cardiac and respiratory monitoring, frequent neurological checks, blood glucose assessment, and identifying any underlying triggers such as infection, low sodium, head trauma, or drug withdrawal. Early recognition and rapid intervention are essential in preventing brain injury and saving the patient's life. As LPNs, your role includes recognizing symptoms, initiating seizure precautions, assisting with airway support, and ensuring medications are administered promptly and safely. A traumatic brain injury occurs when an external force injures the brain. This can happen from a fall, motor vehicle crash, sports injury, assault, or any sudden blow to the head. The initial trauma can cause several types of injury inside the skull. A hemorrhage refers to bleeding within or around the brain, which increases intracranial pressure and deprives brain tissue of oxygen. A contusion is essentially a bruise on the brain, meaning a localized area of swelling and small vessel bleeding caused by the impact. A laceration is more severe and involves tearing of brain tissue, which causes direct damage to neurons and blood vessels. These primary injuries occur at the moment of impact and set the stage for the complications that follow. The slide also highlights what traumatic brain injury can cause, and these represent the secondary injuries. These develop minutes to days after the initial trauma and are often the reason traumatic brain injury becomes life-threatening. Cerebral edema is swelling of brain tissue. When the brain swells, pressure increases inside the skull because there is no room for expansion. This can reduce blood flow to the brain and lead to further damage. Hyperemia refers to increased blood flow to the injured area. Although this is part of the body's healing response, inside the rigid skull, it can worsen swelling and increase pressure. Hydrocephalus can occur if cerebrospinal fluid flow becomes blocked due to swelling or bleeding, causing fluid to accumulate and increase intracranial pressure. One of the most feared complications is brain herniation, when increased pressure forces brain tissue to shift from its normal position. This can compress vital structures that control breathing and heart rate. Ultimately, untreated or severe traumatic brain injury can lead to death. As LPNs, you play a key role in early recognition and monitoring. Watching for subtle neurological changes, reporting a decline in consciousness, noting changes in pupil size or responsiveness, and monitoring vital signs can save a patient's life. Understanding how trauma leads to these secondary complications helps guide nursing actions, such as maintaining head alignment, minimizing stimulation, and ensuring rapid handoff to providers when deterioration is observed. The first type of traumatic brain injury is a concussion. A concussion is considered a mild traumatic brain injury and occurs when the brain is shaken within the skull due to sudden acceleration or deceleration. Although structural changes may not be visible on imaging, the patient can still experience symptoms such as headache, dizziness, nausea, confusion, difficulty concentrating, memory problems, or temporary loss of consciousness. Repeated concussions can have long-term neurological effects, so it's important to emphasize prevention and early evaluation. Next, we have a contusion, which is a bruise on the brain caused by direct trauma. With a contusion, small blood vessels bleed and swelling forms at the site of impact. Unlike concussions, contusions represent actual tissue injury, which may appear on CT or MRI. Patients with contusions are at higher risk for increased intracranial pressure because the bruise takes up space and worsens swelling. The final category on this slide is hematomas, which are collections of blood inside the skull. The two types listed, subdural and epidural, refer to the location where the blood accumulates. An epidural hematoma occurs when bleeding happens between the skull and the dura mater, usually due to an arterial tear such as the middle meningeal artery. Epidural hematomas often develop rapidly and are a true neurosurgical emergency. A classic sign is a brief loss of consciousness followed by a so-called lucid interval and then a sudden deterioration as the bleeding expands. A subdural hematoma occurs when bleeding happens beneath the dura mater, typically from tearing of bridging veins. This type can develop quickly after trauma, but it can also progress slowly over days to weeks, especially in older adults or people taking anticoagulants. Subdural hematomas can cause headache, confusion, personality changes, or neurological decline. The images shown illustrate the location of each hematoma. In the top image, you see an epidural hematoma accumulating outside the dura. In the lower image, the subdural hematoma forms beneath the dura, causing a crescent-shaped bleed. Understanding these injury types helps LPNs recognize early warning signs of neurological deterioration, such as changes in mental status, worsening headaches, vomiting, unequal pupils, or decreased responsiveness. Early communication with the healthcare team can prevent complications and save lives. A brain herniation is one of the most dangerous complications of increased intracranial pressure and traumatic brain injury. Brain herniation occurs when swollen or displaced brain tissue is pushed from one compartment of the skull into another. Because the skull is a rigid, closed space, any swelling, bleeding, or mass effect forces the brain to shift. This shift compresses vital structures that control breathing, heart rate, and consciousness. If untreated, brain herniation rapidly becomes fatal. The image on the slide shows a normal anatomical view in the top illustration and a herniation pattern in the bottom illustration. In the lower image, the lesion, often a hemorrhage, tumor, or severe swelling, creates pressure that pushes the temporal lobe downward into the tentorial notch. This is called a transtentorial or uncal herniation. As the brain shifts downward, it compresses cranial nerve 3, which controls the pupil on the affected side. This is why one classic early sign of herniation is a unilateral dilated pupil that does not react to light. The brainstem may also be pushed downward, causing pressure on the centers that control breathing and cardiac function. As the herniation progresses, patients often show abrupt changes such as decreasing level of consciousness, abnormal posturing, irregular respirations, and changes in blood pressure and heart rate, often described as Cushing's triad. These changes require immediate emergency intervention. Treatment focuses on rapidly reducing intracranial pressure through measures such as hyperventilation, osmotic diuretics like mannitol, surgical evacuation of a hematoma, or placement of a ventriculostomy drain. For LPNs, your role is early recognition. If a patient suddenly becomes harder to wake up, has unequal pupils, begins posturing, or shows a sudden spike in blood pressure with bradycardia, you must notify the healthcare provider immediately and prepare for emergency interventions. Quick action is essential because brain herniation progresses rapidly and is often irreversible once critical structures are compressed. A brain tumor is an abnormal, uncontrolled, or neoplastic growth of cells within the brain, spinal cord, or meninges. These tumors can arise from the neurons, glial cells, meninges, or the structures that support the brain. Even when tumors are benign, meaning they do not spread to other parts of the body, they still pose serious risks because they grow within the closed, rigid space of the skull. This limits the brain's ability to compensate for added pressure or mass. Brain tumors can be classified as primary or metastatic. Primary tumors originate in the brain itself, such as gliomas, meningiomas, or pituitary tumors. Some of these grow slowly, while others, like glioblastomas, grow aggressively. Metastatic tumors, on the other hand, come from cancers that began elsewhere in the body, most commonly the breast, lung, skin, melanoma, or colon. Metastatic tumors are actually far more common than primary brain tumors, especially in adults. A key part of tumor pathophysiology is how these masses affect brain tissue. Tumors can compress nearby structures, pushing on healthy tissue and disrupting normal function. They can also infiltrate brain tissue, growing between cells and interfering with nerve signaling. Both compression and infiltration can impair motor function, cognition, speech, and sensation, depending on the tumor's location. For example, a tumor in the frontal lobe may affect behavior and personality, while a tumor in the cerebellum may cause coordination problems. Finally, the slide mentions increased intracranial pressure. As the tumor enlarges or as swelling develops around it, intracranial pressure rises. This can lead to headaches, vomiting, vision changes, and altered level of consciousness. If not treated, it may progress to herniation, a life-threatening complication. Understanding how tumors cause these changes helps LPNs assess patients effectively, report concerning signs early, and support treatment plans involving surgery, radiation, chemotherapy, or symptom management. Brain tumor diagnosis. The first and most important test listed is the MRI, or magnetic resonance imaging. MRI is the gold standard for diagnosing brain tumors because it produces very detailed images of the brain's soft tissues. MRI can show the size, exact location, and characteristics of a tumor, and it helps determine whether the tumor is likely to be benign, malignant, or metastatic. MRI with contrast enhances visualization by making abnormal tissue stand out more clearly. The next diagnostic tool is an angiogram. This is a study of the blood vessels in the brain, often performed when the tumor appears highly vascular or when surgery is planned. An angiogram involves injecting contrast dye into the bloodstream and taking X-ray images to map the blood vessels feeding the tumor. Identifying the blood supply helps surgeons plan safer operations and avoid major vessels that could cause hemorrhage during removal. A magnetic resonance angiogram, or MRA, is a specialized type of MRI that focuses on the blood vessels without requiring the same level of invasive contrast as a traditional angiogram. MRA is especially useful for evaluating tumors near large arteries or those that may be compressing vascular structures. It can also help distinguish a tumor from other vascular abnormalities. Finally, hormone levels are included because some brain tumors affect the endocrine system, particularly tumors located in or near the pituitary gland. For example, pituitary adenomas may cause abnormal secretion of prolactin, ACTH, growth hormone, or TSH. Measuring hormone levels helps identify these tumors and provides clues about how the tumor is affecting body systems beyond the brain. As LPNs, understanding these diagnostic tests helps you support patient preparation, provide education before imaging, monitor for contrast reactions, and reinforce the importance of follow-up appointments. It also helps you understand why certain symptoms occur and how test results guide the patient's treatment plan. Brain tumor complications occur because tumors take up space in the skull, compress or invade brain tissue, interfere with blood flow, and increase intracranial pressure. The first complication listed is seizures. Tumors can irritate the cerebral cortex, disrupting electrical activity and triggering seizures. Seizures may range from focal episodes to full tonic-clonic seizures, and they may be one of the earliest symptoms of a brain tumor. Headaches are another common complication. Tumor growth increases pressure inside the skull, stretches pain-sensitive structures, and disrupts normal cerebrospinal fluid flow. These headaches are often worse in the morning or when the patient coughs, sneezes, or bends over due to transient increases in intracranial pressure. Memory impairment and cognitive changes occur when tumors affect areas of the brain responsible for learning, judgment, concentration, or personality. Patients may show confusion, slowed thinking, poor problem solving, or mood changes. These changes can progress gradually or appear suddenly depending on tumor location and size. Ataxia refers to unsteady movement or loss of coordination. Tumors affecting the cerebellum or its pathways can cause difficulties with balance, gait, or fine motor skills. This may appear as stumbling, difficulty holding objects, or trouble with activities that require coordination. Hemiparesis is weakness on one side of the body. This happens when the tumor compresses or disrupts signal pathways in the motor cortex. Patients may have trouble lifting an arm or leg, or may experience dragging of one foot. Aphasia is another complication, referring to difficulty speaking or understanding language. Tumors in the left frontal or temporal lobe, such as Broca's or Wernicke's areas, can interfere with speech production or comprehension. Lethargy, coma, and death represent progression of severe neurological compromise. As intracranial pressure rises, brain tissue becomes compressed, blood flow decreases, and oxygen delivery falls. If the pressure becomes extreme, the patient may lose consciousness, progress to a comatose state, and ultimately experience brain herniation leading to death. This highlights why early recognition and treatment are critical. As LPNs, your role is to observe for subtle changes in neurological status, report early warning signs immediately, and support both the patient and family through diagnosis and treatment. Recognizing complications early can prevent irreversible damage. Intracranial surgery is surgery performed inside the skull. These procedures are done when a structural problem in the brain is causing life-threatening pressure, neurological decline, or symptoms that cannot be controlled with medical therapy alone. The first indication listed is hematoma. This refers to a collection of blood within the skull, often caused by trauma or rupture of a blood vessel. Depending on the location, such as epidural or subdural, hematomas can expand rapidly and compress the brain. Surgery may be needed to remove the clot, stop the bleeding, and relieve pressure. Quick intervention is critical because untreated hematomas can lead to brain herniation and death. The next indication is a tumor. Brain tumors may require surgery to remove as much of the mass as possible, to obtain a biopsy for diagnosis, or to relieve pressure on the brain. Surgical removal may be curative for some tumors, while for others it helps reduce symptoms or allows additional treatment such as radiation or chemotherapy to be more effective. Another indication is arteriovenous malformation, or AVM. An AVM is a tangle of abnormal blood vessels that can rupture and cause hemorrhagic stroke. Surgery may be performed to remove or repair the malformation before it bleeds, or after bleeding has already occurred. Other procedures such as embolization or radiosurgery may be used in combination with open surgery. Trauma is also a major reason for intracranial surgery. Severe head injuries can cause skull fractures, penetrating injuries, swelling, or bleeding that require immediate surgical intervention. The goal is to relieve pressure, repair damage, and prevent secondary brain injury. Finally, surgery may be performed for seizures that do not respond to medication. In certain cases, neurosurgeons can remove the area of the brain where seizures originate. This is typically done only after extensive testing and mapping to ensure that removing the tissue will not affect essential functions like speech or movement. For LPNs, understanding these indications helps you anticipate which patients are most likely to require surgery, recognize early warning signs of neurological deterioration, and support patients and families through the surgical process. You also play a key role in post-operative monitoring, watching for changes in level of consciousness, pupil response, or signs of infection. Patients who undergo intracranial surgery often experience a great deal of fear and uncertainty, so the LPN's role in education and emotional support is essential. During the preoperative phase, reinforcement of patient education helps reduce anxiety and prepares the patient for what to expect immediately after surgery. This includes reviewing the purpose of the procedure, anticipated length of recovery, the presence of surgical drains or dressings, and the importance of staying still after surgery to protect the surgical site. Anxiety control is also a major component of preoperative care. Patients may worry about permanent neurological deficits, pain, or the possibility of not waking up after anesthesia. The nurse can encourage the patient to express concerns, answer questions within their scope, and involve family members for emotional support. Relaxation strategies or preoperative medications may also be ordered to help reduce anxiety. Introducing the patient to the intensive care unit or ICU prior to surgery can also help reduce stress. Many intracranial surgery patients spend time in the ICU right after their operation for close monitoring. A brief visit or explanation of the environment, such as monitors, alarms, and frequent neurochecks, helps decrease fear of the unknown and prepares the patient for what they will experience when they wake up. Another important consideration is postoperative risks. After intracranial surgery, patients are at high risk for swelling, bleeding, or changes in intracranial pressure, all of which can reduce blood flow to the brain, causing ineffective cerebral tissue perfusion. Nurses must closely monitor neurological status, pupil responses, vital signs, and changes in behavior or level of consciousness. Risk for infection reflects the seriousness of any break in the skull or meninges. Surgical wounds, drains, or devices such as ventriculostomy catheters create pathways for infection. Monitoring temperature, wound appearance, drainage, white blood cell count, and reporting early signs of meningitis or wound infection are key parts of care. Disturbed body image may arise if the patient has visible incisions, swelling, or hair removal from the surgical site. The nurse should provide emotional support, encourage expression of feelings, and involve mental health resources if needed. Finally, deficient knowledge is common because patients and families may not fully understand activity restrictions, medication regimens, seizure precautions, or symptoms requiring emergency attention. Reinforcement of post-operative teaching focuses on protecting the surgical site, preventing increased intracranial pressure, recognizing warning signs, and ensuring adherence to follow-up appointments. In all phases, LPNs play an important role in patient safety, comfort, and ongoing observation, which greatly influences recovery outcomes. A herniated disc is a common cause of neck, back, and radiating nerve pain. To understand what happens during a disc herniation, we first need to visualize the structure of the intervertebral disc. Each disc has a tough, fibrous outer layer called the annulus fibrosus and a gel-like center called the nucleus pulposus. When we talk about herniation, we mean that this soft center has pushed through a weakened or torn area of the outer layer. As the nucleus pulposus bulges outward, it can compress the nearby spinal nerve roots. The nerve roots exiting the spinal canal control sensation and motor function in specific parts of the body. Compression of these nerve roots causes symptoms such as radiating pain, numbness, tingling, muscle weakness, or loss of reflexes. Pain often follows a dermatomal pattern based on which nerve is affected. Herniated discs most commonly occur in the cervical spine and the lumbar spine. The cervical region is vulnerable because of constant movement and the weight of the head, while the lumbar region absorbs the majority of body weight and stress, especially during lifting or twisting. Patients may report symptoms such as sciatic pain down the leg or radicular pain down the arm, depending on the location. Diagnostic testing helps confirm the location and severity of the herniation. MRI is the primary imaging method because it clearly shows soft tissues, including discs, nerves, and surrounding structures. A myelogram may be used when MRI is not possible. During a myelogram, contrast dye is injected into the spinal canal, and X-rays or CT scans are taken to visualize compression on nerve roots or the spinal cord. As nurses, we play a key role in helping patients understand their diagnosis, monitoring for worsening neurological symptoms, and reinforcing safe mobility and activity modifications while they undergo treatment. Spinal stenosis is a condition where the spinal canal becomes narrowed and begins to compress the spinal cord or spinal nerve roots. This MRI image shows a classic example of that narrowing, where the normally open canal is visibly pinched or constricted. As nurses, it's important for us to understand what this narrowing means clinically. Spinal stenosis can occur anywhere along the spine, but it is most common in the cervical and lumbar regions. In the cervical spine, narrowing can affect both the spinal cord and the nerve roots, leading to symptoms such as neck pain, numbness or tingling in the arms or hands, weakness, and even problems with gait and balance if the spinal cord is compressed. In the lumbar spine, spinal stenosis typically affects the nerve roots rather than the spinal cord itself, because the actual spinal cord ends around L1, L2. Patients with lumbar stenosis often describe burning, aching, or tingling that radiates down the legs. A key characteristic symptom is neurogenic claudication, leg pain that worsens with standing or walking and improves when the patient sits or bends forward, because flexion temporarily widens the spinal canal. The image here illustrates how severe narrowing can become and how it can impact neurological function. Compression of the spinal cord or nerve roots reduces blood flow and irritates the neural tissue, contributing to pain, weakness, and altered sensation. Without treatment, severe stenosis can lead to permanent neurological deficits. Diagnosis is typically confirmed with MRI, which is the imaging modality shown here because it clearly shows soft tissue structures including the spinal cord, intervertebral discs, ligaments, and surrounding bone. Some patients may need CT scans with or without contrast if MRI is contraindicated. As LPNs, our role includes monitoring neurological status, educating patients about activity modification, supporting pain management, and recognizing red flag symptoms such as rapidly worsening weakness or loss of bowel or bladder control. A spinal cord injury occurs when trauma damages the spinal cord's nerve fibers. These fibers are responsible for carrying messages between the brain and the rest of the body. When they are damaged, those messages can become slowed, disrupted, or completely blocked. The level and completeness of the injury determine which functions are affected. Pathophysiologically, the initial trauma injures the nerve fibers directly, but the damage doesn't end there. Swelling, bleeding, and inflammation occur quickly after the injury, and these secondary processes can worsen the neurological deficits. Because the spinal cord is contained within the rigid vertebral canal, swelling has nowhere to go, causing compression and further loss of blood flow, which can lead to permanent loss of function. The primary causes of spinal cord injuries are shown here. Motor vehicle crashes, or MVCs, remain the leading cause of traumatic spinal cord injury across all age groups. Falls are the second most common cause, especially among older adults. Sports injuries, such as diving accidents, football injuries, or high-impact recreational activities, can also result in SCI. Assaults, including gunshot wounds and stabbing injuries, are another major category. It's important for LPNs to recognize that mechanisms of injury provide clues about the likelihood of cervical, thoracic, or lumbar involvement. As frontline nurses, you will often be involved in the initial assessment and stabilization of patients with suspected spinal injuries. Protecting the airway, ensuring spinal immobilization, and recognizing signs of neurological deficits, such as weakness, loss of sensation, or difficulty breathing, are all essential. Understanding the cause of injury helps you anticipate complications such as neurogenic shock, respiratory impairment, bowel and bladder dysfunction, and autonomic dysreflexia in higher-level injuries. The primary goal of surgery in patients with spinal cord injury is to stabilize the spine in order to prevent additional neurological damage. After the initial trauma, the spine may be unstable due to fractures, ligament tears, or displacement of the vertebrae. Without stabilization, even minor movement can worsen spinal cord compression and increase the patient's deficits. There are several methods used to stabilize the spine depending on the location and severity of the injury. One common device is the halo brace, which you see pictured on this slide. A halo brace provides rigid immobilization of the cervical spine. It's attached to the skull using metal pins, and the ring is connected to a vest worn on the torso. This device keeps the neck completely immobilized, so the vertebrae can heal and prevents any movement that could damage the spinal cord further. LPNs play an essential role in halo pin site care, monitoring for infection, checking skin integrity under the vest, and ensuring proper alignment. Surgical stabilization may also involve the placement of rods, commonly called Harrington rods or other fixation systems. These rods are inserted along the spine and secured with screws to provide internal stabilization after fractures or vertebral displacement. In some cases, surgeons may use spinal fusion to permanently join vertebrae together, further increasing structural stability. External supports such as corsets, braces, or a body cast may also be used depending on the injury location. These devices help limit motion and support the spine while healing occurs. As nurses, it is important to monitor for pressure points, assess breathing if the brace or cast is restrictive, and check skin integrity frequently. Teaching the patient how to properly apply, remove, and maintain the brace is also part of your role. Surgical stabilization is often combined with medical management and rehabilitation. Your nursing care will focus on pain control, early mobilization with support, education on spinal precautions, and continuous monitoring for complications such as infection, impaired mobility, and respiratory difficulty, especially in cervical injuries. Spinal shock is a temporary condition that occurs immediately after a spinal cord injury. During spinal shock, the spinal cord below the level of injury stops functioning completely. This happens because the normal reflex activity is lost, and communication between the brain and the body is disrupted. A major feature of spinal shock is disruption of the sympathetic nervous system. Remember that the sympathetic system controls the body's fight or flight responses, such as raising heart rate, constricting blood vessels, and maintaining blood pressure. When the sympathetic nerves are suddenly damaged, the body loses these automatic functions. One of the first clinical changes we see is vasodilation. Because the blood vessels are no longer receiving sympathetic signals to stay constricted, they open up widely. This leads to hypotension or low blood pressure because the blood is now spread out over a larger vessel area. At the same time, the heart may begin to beat more slowly, a condition called bradycardia. This occurs because the parasympathetic nervous system, the rest and digest system, remains active while the sympathetic system is no longer balancing it. Loss of sympathetic control also affects body temperature regulation. Patients often develop hypothermia because the body can no longer constrict blood vessels to conserve heat. Another hallmark of spinal shock is the loss of bladder and bowel function. Without nerve signals, the bladder and bowels cannot contract effectively, which leads to retention of urine and feces. This is important for nurses to recognize early because retention increases the risk for infection, skin breakdown, and autonomic dysreflexia later, especially in injuries above T6. Spinal shock is temporary and usually lasts days to weeks. The return of reflexes is one sign that spinal shock is resolving. As nurses, our responsibilities include monitoring vital signs, maintaining airway and perfusion, preventing complications, managing bladder and bowel function, and providing education to both the patient and family. Skeletal traction applies a continuous pulling force directly to the skeletal structure using pins inserted into the skull. This method is commonly used in unstable cervical fractures to realign the vertebrae, reduce spinal cord compression, and maintain immobilization until surgery or definitive stabilization can be completed. The left image shows Crutchfield tongs, and the right image shows Gardner-Wells tongs. Both systems involve pins or tongs placed into the outer skull table, attached to a rope and pulley system connected to calibrated weights. These weights must always hang freely and never touch the floor to maintain consistent traction. As LPNs, your responsibilities include closely monitoring pin sites for infection, maintaining strict alignment, assessing neurological status frequently, and ensuring that the traction equipment is never adjusted by anyone except trained personnel or ordered by the provider. Be aware that patients in cervical traction are at high risk for pressure injuries, impaired skin integrity, and respiratory complications due to limited mobility. Regular skin care, repositioning while keeping alignment, and assisting with ADLs are essential aspects of care. Dementia is not a specific disease, but a broad term describing a decline in cognitive functioning severe enough to interfere with daily life. Dementia affects memory, reasoning, language, judgment, and behavior. It is progressive, meaning symptoms worsen over time, and it is most commonly caused by Alzheimer's disease, although vascular dementia, Lewy body dementia, and frontotemporal dementia are also common causes. When we say there is significantly impaired intellectual functioning, we mean the person has difficulty with memory, learning new information, and making decisions. They may repeat questions, forget important events, or become disoriented in familiar environments. Dementia also impairs normal activities and relationships. Patients may struggle with cooking, managing medications, paying bills, or maintaining social interactions. Family members often notice changes long before the patient does, which can lead to stress and caregiver burden. Problem solving and emotional control also decline. Patients may have trouble planning steps, following instructions, or coping with frustration. Small challenges can lead to emotional outbursts because the brain's ability to regulate responses is deteriorating. Personality changes are common. A previously calm person may become irritable or suspicious. Some patients become withdrawn, while others become impulsive or inappropriate. These changes can be distressing for families who feel like they are losing the person they once knew. Behavioral problems often develop as dementia progresses. Examples include wandering, agitation, sundowning, sleep disturbances, and aggression. These behaviors are not intentional, they are caused by changes in the brain. As LPNs, we focus on ensuring safety, using calm communication, reducing triggers, and supporting caregivers. Overall, our role as nurses includes recognizing early signs, maintaining structure in the patient's routine, promoting independence when possible, preventing injury, and educating families on what to expect as the condition progresses. Signs and symptoms of dementia. One of the earliest and most noticeable changes is that recent memory is affected first. This means the patient may forget conversations that happened earlier today, repeat questions, misplace items, or forget appointments. These changes are often subtle at first, but they gradually worsen. As dementia progresses, remote memory becomes affected later. Remote memory includes older memories, such as childhood events, long-term relationships, or meaningful life experiences. Patients often hold on to these older memories longer, which is why a patient may recognize a family member from years ago but not remember what they ate for breakfast. Eventually, however, even remote memories begin to fade. Another major sign of dementia is difficulty performing simple tasks. Patients gradually forget how to do activities they have done their entire lives, like cooking, using the telephone, dressing, or managing personal hygiene. This loss of executive function is caused by deterioration in the brain's ability to sequence and plan actions. Wandering is a common and dangerous symptom. Patients may walk away from home or a facility, sometimes with no understanding of where they are going. Wandering increases the risk of injury, exposure to weather, or becoming lost. Safety interventions, such as alarms, supervision, and structured routines, are essential. Aphasia is another key sign. Aphasia refers to difficulty using language, either speaking, writing, or understanding what others are saying. Patients may struggle to find words, use inappropriate words, or become unable to express themselves at all. This contributes to frustration and behavioral issues. Behavioral problems are often caused by confusion, fear, overstimulation, or unmet needs. Examples include agitation, yelling, restlessness, nighttime wandering, resistance to care, or sudden mood changes. As nurses, we look for patterns and triggers to help decrease these behaviors. In the late stages of dementia, patients eventually become totally dependent on caregivers for all activities of daily living. They may lose the ability to eat, dress, bathe, walk, or use the bathroom without assistance. At this stage, the goals of care focus on comfort, safety, dignity, and supporting caregivers through an emotionally challenging time. Delirium is a temporary and often sudden disturbance in mental functioning. Unlike dementia, delirium develops quickly, sometimes within hours, and it fluctuates throughout the day. Patients may be alert and oriented 1 minute and confused or agitated the next. This rapid onset is one of the key differences between delirium and dementia. Delirium is considered a medical emergency because it signals that something serious is happening in the body. The brain is not functioning normally, and that almost always means there is an underlying medical problem, like infection, metabolic imbalance, oxygen deprivation, medication toxicity, or untreated pain. For LPN students, the most important takeaway is that delirium is not a normal part of aging and should never be ignored. The priority in delirium management is to identify and correct the underlying cause. Treating symptoms alone is not enough. For example, if delirium is caused by pain, we need to address that pain appropriately. If hypoxia, low oxygen, is the cause, the patient may need supplemental oxygen or treatment for the respiratory problem. Medications are also a common trigger, especially benzodiazepines, anticholinergics, or polypharmacy in older adults. Illnesses like urinary tract infections, pneumonia, dehydration, or sepsis are very frequent causes in hospitalized elderly patients. Once the underlying cause is treated, the delirium often improves quickly. This is why LPNs play a critical role. We are often the first to notice sudden confusion, restlessness, changes in alertness, or unusual behavior. Early recognition prevents complications, supports patient safety, and decreases the risk of falls or injury. Parkinson's disease is a chronic progressive neurological disorder that primarily affects movement. The key problem in Parkinson's disease is the destruction of the substantia nigra, an area in the midbrain responsible for producing dopamine. Dopamine is a neurotransmitter that helps regulate smooth, coordinated muscle movements. As the dopamine-producing cells die, the levels of dopamine drop significantly. When dopamine decreases, there is a relative excess of acetylcholine. These two chemicals must stay in balance for the body to carry out semi-automatic movements, things we do without thinking, like swinging our arms when we walk, blinking, swallowing, or keeping our posture steady. The imbalance causes the classic motor symptoms of Parkinson's disease, such as tremors at rest, rigidity, bradykinesia, which means slowness of movement, and postural instability. The illustration on this slide shows common features of Parkinson's disease. You'll notice the mask-like facial expression, which comes from decreased facial muscle movement. Patients often have a soft monotone voice, drooling, and difficulty swallowing, known as dysphagia. Resting hand tremors are another classic sign. They often start on one side and may look like pill rolling. Many patients struggle with constipation and urinary frequency because Parkinson's disease also affects the autonomic nervous system. As mobility declines, the knees and hips flex forward, causing the center of gravity to shift. This results in the characteristic shuffling gait with short steps. These gait changes, combined with rigidity and slowed movement, place patients at very high risk for falls. Understanding these signs helps LPNs provide safe care, anticipate complications, and support patient independence as much as possible. Huntington's disease is a rare but severe hereditary neurological disorder. The key point to understand is that Huntington's disease is genetic and follows autosomal dominant inheritance pattern. This means that a person only needs one copy of the defective gene from either parent to develop the disease. Each child of an affected parent has a 50% chance of inheriting it. Symptoms usually begin in mid-adulthood, although they can appear earlier or later. At the pathophysiological level, Huntington's disease causes progressive degeneration of specific parts of the brain, especially the basal ganglia and the cerebral cortex. The basal ganglia help regulate movement and emotional responses, while the cortex is responsible for higher-level thinking. As these areas break down, patients develop the classic symptoms of Huntington's disease: involuntary jerking or writhing movements called chorea, changes in personality, difficulty with speech and swallowing, and progressive cognitive decline. The photographs on this slide illustrate choreiform movements. These are rapid, unpredictable, dance-like motions that patients cannot control. Because the movements occur even at rest, patients are at high risk for falls, exhaustion, and injury. As the disease progresses, movement control becomes extremely limited, and patients eventually lose the ability to walk, talk, and perform activities of daily living. There is no cure, so treatment focuses on symptom management, safety, and supporting the patient and family through the disease's long course. Alzheimer's disease is the most common form of dementia. It is considered a progressive, degenerative neurological disorder, meaning it gets worse over time as more nerve cells in the brain deteriorate and die. This gradual loss of neurons leads to cognitive decline, memory loss, and behavioral changes. Two hallmark abnormalities occur inside the brain of a person with Alzheimer's disease. The first is the formation of neurofibrillary tangles. These tangles are twisted fibers made from a protein called tau. When tau becomes abnormal, it collapses the internal support structure of the neuron, causing the neuron to lose its ability to transport nutrients. This breakdown eventually results in cell death. Higher levels of tangles are directly associated with worsening cognitive impairment. The second key change is the development of neuritic plaques, also called amyloid plaques. These plaques are made of a sticky protein called beta amyloid. They accumulate outside the neurons and interfere with communication between nerve cells. These plaques also trigger inflammation in the brain, which further damages healthy tissue. Together, tangles and plaques disrupt the brain's normal functioning, causing widespread neuronal death, shrinking of brain tissue, and impaired ability to process and store information. As LPNs, understanding these physical changes helps us appreciate why the symptoms progress the way they do, and why there is currently no cure, only supportive care and medications that may slow the progression temporarily. In stage 1, the hallmark symptom is increasing forgetfulness. Patients might misplace objects, forget appointments, or repeat questions without realizing it. These changes are often subtle at first and may be mistaken for normal aging. However, the pattern becomes more noticeable when memory lapses begin to affect daily functioning. Stage 2 includes a more pronounced and progressive memory loss. At this stage, many patients have trouble retaining new information, following instructions, or recalling recent events. Behavioral and emotional changes commonly develop as the disease progresses. Irritability may occur because the patient becomes frustrated with their declining abilities. Depression is also common as they begin to recognize the cognitive changes happening to them. Aphasia, or difficulty finding words and forming coherent speech, often emerges during stage 2. As communication becomes more difficult, patients may withdraw or misinterpret their surroundings. Sleep disruption is also common due to altered sleep-wake cycles. Some patients begin experiencing hallucinations, which can be frightening, and in later stages, seizures may occur due to widespread neuronal damage. Overall, these symptoms reflect progressive neurological decline. As LPNs, our role is to observe changes early, ensure patient safety, support caregivers, and help patients maintain as much independence and comfort as possible. The third and final stage of Alzheimer's disease, which represents the most severe level of cognitive and physical decline. By this stage, the patient experiences profound neurological deterioration, and complete dependence on caregivers becomes unavoidable. As LPNs, our role focuses heavily on maintaining dignity, ensuring comfort, and supporting the family through the progression of the disease. One of the most significant changes in Stage 3 is the loss of the ability to perform any activities of daily living independently. Patients require total assistance with eating, bathing, dressing, toileting, and mobility. This dependence is not from unwillingness, but from the brain's inability to process and carry out even the most basic tasks. As Alzheimer's disease advances, the patient loses bowel and bladder control. This results from damage to the parts of the brain responsible for controlling sphincter muscles and responding to internal cues. Incontinence care becomes essential to prevent skin breakdown, infections, and discomfort. Emotional control is also significantly impaired in this stage. The patient may experience sudden crying, anger, apathy, agitation, or emotional flatness. These reactions are neurological, not intentional. It is important for LPNs to model patience, provide reassurance, and use calm, consistent communication. Another hallmark of late-stage Alzheimer's disease is the inability to recognize significant others, including spouse, children, or close caregivers. This can be emotionally very difficult for families. The patient is not intentionally withdrawing. This occurs because the areas of the brain responsible for memory storage and facial recognition are severely damaged. Ultimately, Alzheimer's disease is a terminal condition. Death typically results from complications such as infections, aspiration pneumonia, malnutrition, or immobility-related decline. Our nursing care at this point focuses on comfort, prevention of suffering, and supporting the family with anticipatory guidance and education. When a patient is assessed for possible Alzheimer's disease, the diagnosis is not made with just one test. Instead, it is a clinical diagnosis built from a combination of history, physical exam findings, and imaging. As LPNs, it's important to understand how each of these pieces contributes to the overall picture. The first part of the diagnostic process is obtaining a thorough history. This includes input from the patient when possible, but also from family members or caregivers who can describe changes in memory, behavior, daily functioning, and personality. Because early Alzheimer's disease can be subtle, this collateral history is essential. The physical examination helps rule out other causes of cognitive decline. The provider assesses neurological function, mental status, reflexes, gait, and any signs of stroke, Parkinsonism, or systemic illness. The physical exam doesn't diagnose Alzheimer's disease directly, but it helps identify or exclude other conditions that may mimic dementia. MRI imaging plays an important role in the evaluation. An MRI allows the provider to look for brain shrinkage, especially in the hippocampus and temporal lobes, areas heavily affected by Alzheimer's disease. It also helps rule out tumors, strokes, normal pressure hydrocephalus, or vascular dementia. PET scans and SPECT scans provide functional information, meaning they show how well the brain is using glucose or perfusing blood. In Alzheimer's disease, these scans may show reduced activity in certain regions of the brain before structural changes appear on MRI. PET scans can also detect amyloid plaques in advanced facilities, although this is not routine everywhere. Finally, autopsy remains the only definitive diagnostic method. It allows direct visualization of the neurofibrillary tangles and amyloid plaques that characterize Alzheimer's disease. While this doesn't help the patient during life, it is important for confirming diagnosis and supporting research. As LPNs, knowing these tests helps us support the patient and family throughout the diagnostic process, answer basic questions, and reinforce what the healthcare team is explaining. This concludes the presentation.